Yeah, thank you. I'm really pleased to be joining you this evening. I feel quite privileged to be among such talented speakers. And thank you to the audience in advance for listening to this talk. I'm going to share some experience of how our team at LenusHealth and our sister company StormID, who are both based in Edinburgh and Scotland, are designing ethical patient services and incorporating machine learning. To set the scene, I'm going to kick off with a bit of context. I'm going to talk about COPD and the remote monitoring solution that we've built to support the management and care of patients with COPD. So COPD is a chronic obstructive pulmonary disease. It is a progressive and incurable lung disease. It is the second most common cause of emergency hospital admission in the UK, and it is predicted to be the third leading cause of death worldwide by 2030. 1.2 million people are affected by COPD in the UK, and the predicted yearly cost to the NHS is around £2.5 billion. The disease has a significant operational and financial burden on the NHS, and the disease is very challenging for patients to manage. Patients with COPD can experience frequent exacerbations or flare-ups, and repeated hospital admissions, which cause distress and long-term deterioration of their condition, directly impact their quality of life. Having an exacerbation of COPD can involve a feeling of breathlessness, and patients have told us that they feel like they're suffocating. This understandably can create a feeling of anxiety or panic in patients as they become worried about having another exacerbation, and in turn this can increase their breathlessness and subsequently put them at risk of another exacerbation. Reducing these episodes could greatly increase the quality of life of the patient, as well as providing significant operational and financial improvement to the NHS. Since 2018, we've been working with the NHS Greater Glasgow and Clyde, a health board in Scotland, to design and develop a remote monitoring service for patients with COPD. In Glasgow, the Digital COPD Remote Management Service started as a clinical trial, and it was rolled out during the pandemic to support clinically vulnerable patients from the comfort and the safety of their home. The digital service has two apps, one for the patient and one for the clinicians, and data is collected from three sources: patient-reported outcomes, or PROs as we call them, which are a series of patient questionnaires that the patient answers on a daily, weekly and monthly basis from their app. Data also comes from connected devices, and we frequently use Fitbits and other wearable devices, and also non-invasive ventilation machines. The wearable devices capture data on activity, sleep and heart rate. And this is shared together with data from the electronic health record. The system also enables two-way communication and sharing of data to support patients, and patients can use that to send messages to their clinicians about their symptoms and medications. The first patient was onboarded in 2019 as part of a clinical trial phase, and 225 patients took part during that phase. At the end of the clinical trial phase, we had some really positive success metrics. Survival rate at year one doubled. There was a 54% reduction in admissions, 4.5 fewer annual bed days per patient. Anecdotally, patients appeared to have increased engagement and self-management of their condition, and I think that was due to their increased awareness of their overall health and their symptoms. There were fewer community exacerbations reported, and there were an average of 3 fewer face-to-face appointments required. The service is now live as part of routine patient management and has 600 patients involved. By reducing unnecessary hospital visits and admissions, the service enables greater inclusivity in access to care by removing lost wages and the travel cost barriers that are associated with attending appointments. And based on a demonstrated mean reduction of that 4.5 general ward bed days per user per year, projections of around 500 users of the service would result in 85,844 kilograms of CO2e reduction in admissions. And similarly, the reduction in the 3 face-to-face outpatient appointments on average would no longer be required. With a similar group of patients, with 70% journeys usually made by car, this could cause an additional 10,686 kilograms of CO2e reduction in admissions. So there's an overall total there of around 96,000 kilograms of CO2e admissions that could be avoided. And that is the equivalent to powering 111 homes or driving around 784,000 kilometres. So it does feel good that digital remote monitoring services have a role in achieving a greener NHS. So with patients completing their patient-reported outcomes or their daily questionnaires, on average at least 3 times a week, and wearable devices generating data around the clock, the volume of data that is generated by patients using the service is vast. At present, the data can be used when reviewing a patient, whether that's because they've messaged the service to say that they feel unwell, or it may be part of a routine or emergency appointment. But we're looking into how we can unlock the potential for this data to be used much more proactively to identify trends in patient health and, as a result, predict deteriorations. And in an ongoing clinical feasibility study called the AI Award, which is funded by NHSX, who are now the NHS Transformation Directorate, we're actively exploring the use of machine learning to make risk predictions about patient health and use data that is generated and collated as part of that digital COPD service. My colleagues in the data science team are developing models for a 12-month mortality rate, a 3-month hospital readmission rate, and a 72-hour exacerbation rate. And as digital designers and researchers, we're often operating in that intersection between people and technology, and a critical part of the role is ensuring the well-being is central to decision-making. So the data has the power to provide rich insight, but without careful informed design, it could potentially do more harm than good, and that caution is central to the design of these models. My colleagues in our user research team did some research about how to design services that appeal to patients and clinicians, and I'd like to share a little of what we're learning from that. The technology doesn't matter to people as much as the impact of it does, so it's important to explain the benefits to the users in simple but accurate language. Transparency and trust matter. We think it is important to create a service that builds on the foundations of a good relationship and give people confidence that they can trust the whole system. We found that people, when they understand the why, they can make more informed decisions that are right for them. And so long as healthcare is for humans, human interaction still matters. And data and technology should be only part of the system. Relationships with trusted members of clinical teams are an integral part of patient care and patient trust in a service. So I hope that quick canter through is evident that there maybe is a revolution happening in healthcare. And that data and AI-driven health tech can significantly improve how patients engage with their care, empowering them to better understand their condition and how it can be managed. And these new health tech solutions are also changing the clinical practice for disease diagnosis and management for conditions like COPD and heart failure and many others. And they can help to reduce the pressures on healthcare providers, by way of example, by facilitating early discharge. The COVID-19 pandemic has accelerated clinical pathway transformation in many areas across the healthcare system, and we've seen patients become increasingly familiar and comfortable to a large extent with the idea of remote consultations and the use of advancing technologies in everyday care. I wanted to share just quickly why I work in this space. I have mostly worked on projects and services, as Helen mentioned at the beginning, where technology enables change and improvement. And I've done that in a few different sectors. But the sense of value in doing that in healthcare is really significant. And as we'll all know, the NHS really needs support in looking after us all. So I'm really pleased to be part of the change that's helping them and the patients. We hear some patient testimonials about how the technology gives them a feeling of being connected and of also giving their autonomy back when they're used to feeling so reliant on carers and family. It's really inspiring, and it's really moving to work in this space. I'd like to just say thank you for having me. I'd like to say thank you to DXW, one of the sponsors, for inviting me to speak today. I have been long inspired by Ada Lovelace, and so much so that my daughter, who's pictured here and is now 5, is called Ada, and this is her reading her Ada Lovelace book. And this is my Ada Lovelace book. Thank you for listening. And just one final comment from me. If anybody is interested in working in this space, Lenus are hiring, and you can find out information about the roles available on our careers page or on our LinkedIn page, or you can drop me an email.